Uh, Good day, sir, everyone. Good day, everyone, and welcome to our webinar on the role of JKI in RA and PsA. We have two renowned speakers with us today, Dr. B.D. Pandey, a consultant rheumatologist from Fortis Hospital, Noida, and Dr. Nikhil Gupta, a consultant rheumatologist from South Hospital. They will be sharing their insight and experience on the uses of JKI in the treatment of rheumatoid arthritis and psoriatic arthritis, respectively. RA and PsA are two autoimmune diseases that can significantly impact the quality of life of those affected. However, with the advancement in the medical science, we know that JAK inhibitors that can provide relief from symptoms and provide the overall outcome of the patient. We believe that this webinar will be insightful and informative for all of you. Our goal is to equip you with the necessary knowledge and the tools that you can use in your practice or personal life. Without further detail, let's welcome our first speaker, Dr. B.D. Pandey. Over to you, sir.
Thank you. At outset, I thank everyone who is taking off time. Today is the first day of the IPL, and I know everyone would like to go back and see the match. So I won't waste time, but we'll have a very reasonable, understanding of JAK inhibitors in psoriatic arthritis. So I'm going to share the slide. I hope so that at the end of this meeting, we are able to see a reasonable understanding about the JAK inhibitor. So before we move, I have to say at outset that these sets of slides have been taken from the Medscape, and these are very, very good in terms of quality. And Laura Coates is the original person who has provided it for the teaching and learning purposes. Now, when it comes to psoriatic arthritis, we think it's an arthritis and a skin involvement. But the problem is, this is actually a very complex disease, and you have multiple domains. So if as a car has multiple areas, say, for example, it has an engine, it has a gearbox, it has certain electrical components inside the battery, it has a transmission, etc. And that makes a car complete. So understanding the overall the disease of the disease is very important before we share our ideas. So when it comes to the joint disease, the skin is one of the areas. This is how the patients are identified majority of the time. But many times you can also see, or in a remote number of patients, the skin may not be the predominant component, it may be the joint component. And there is another problem called enthesitis, which is basically a problem where our ligaments or tendons are touching the bones or meeting the bone. So that inflammation is called as enthesitis. And there's a unique condition called dactylitis, where one of your digit, the fingers of the hand and the toes of the leg, when they're grossly swollen and they look like a sausage, they're called dactylitis, very painful. Sometimes you have a spine involvement, so it's an axial disease. Then obviously sometimes nail is involved. And then you have the peripheral arthritis where multiple types of joints can be involved, even the terminal, which is called as distal interphalangeal joints, the proximal interphalangeal joints, the MCP, the wrist, the elbow, the shoulders. Any number of joints can be involved. It can be one or two joints, monoarticular, it can be oligoarticular, it's less than 4 but more than 1, or it can be polyarticular, or it can be even arthritis mutilans, which by word it means a devastating disease or its consequence. And then when you have a joint disease with psoriasis or psoriatic arthritis as overall, you also have to understand the implication of this disease on certain other areas, which is not joint or skin or anything else. They include your brain, where it can cause immense amount of depression. Then you have the heart, which gets involved, and that causes increased amount of cardiovascular disease. And then you have the metabolic syndrome, where you can get uric acid high, the cholesterol high, and so many things. Now, why it is so important? It is important because if I understand the disease in totality, I will be able to understand how I should treat an individual as an individual, not as the matter of science alone. It has to be individualized. Now, if a person has a metabolic syndrome where he has a cholesterol levels which are very high, you have to give a cholesterol lowering therapy. And if there's an associated diabetes, you have to control the diabetes also. So you have to become a diabetologist. And a depression, it needs to be controlled. The cardiovascular complication needs to be controlled. So already the patients are having 5 or 6 or 7 drugs of other systems, because these are comorbidities in psoriatic arthritis. And if the person is obese, you give any drug, it does not give the best result. It is suboptimal for that individual. So these problems are actually compounding the overall musculoskeletal problem that we as a rheumatologist understand well, but we need to also understand this. And this actually makes the whole treatment exciting to us, because this is how you start calculating how many pills, how much is one pill interacting with other, how much is the liver dysfunction going to happen with the drug A, B, C, or D. And that's how the science is. Now comes to the question, how do you treat this disease? So if you ask me, the drugs that are known to treat this disease, they are very simple. They are the conventional synthetic DMARDs. And these are the conventional drugs, which are the classical example: methotrexate, leflunomide, sulfasalazine, cyclosporin, or tacrolimus. These are the basic drugs that we use in psoriatic arthritis. We don't use hydroxychloroquine much. We don't use azathioprine much in this disease. But these are the 5 or 6 drugs, which are the conventional drugs that we use for psoriatic arthritis. And nevertheless, with all the drugs that we had in the conventional synthetic DMARDs, quite a substantial number of patients do not get adequate disease control. So we traditionally treat all the patients with conventional synthetic agents. And then we add other drugs, and those drugs can be either biological drugs or the targeted drugs. And if you see in the targeted drugs, these drugs are the small molecules. These are oral drugs, and one of them drug is JAK inhibitors. And here today we will be talking of tofacitinib and some amount of other drugs which are part of JAK inhibitors used in or licensed in psoriatic arthritis. There's another small molecule called PDE4 inhibitors called as apremilast, and both these drugs are available in India and we use in plenty. But the overall experience of controlling this disease started happening when we got the biological drugs were difficult to treat. Psoriatic arthritis were treated by TNF inhibitors like adalimumab, infliximab, golimumab, etanercept. However, certolizumab is not available in India. So we use out of these 5-4 drugs which are available in India. And now we have IL-17 inhibitors other than secukinumab, ixizumab, which is available. So ixizumab is very exciting drug. And then comes the other drugs which are going to be available or is now available. One is ustekinumab, which is Stelara, which is also approved for Crohn's disease, which is an inhibitor of IL-12-23 pathway, and the guselkumab is inhibitor of IL-23, and that subprotein that is it blocks is P19. So this is how these biological drugs, and we need to find out the best. So there is, a distinction that EULAR does, and it makes things very simple. They are very practical in their approach, and they try to understand which patient is suffering from which component, what is the actual problem, and then they treat accordingly. So in 2015, if you see the guidelines which were made for psoriatic arthritis, they were basically like peripheral disease, enthesial disease, and axial disease. So they identified only 3 predominant components. Now they say there's an oligoarticular disease, only 1 or 2 joints involved. Then there's a polyarticular component. Then there's an enthesial disease. There's a predominantly an axial disease, and things will change. So these are the updates. So as an individual who has to promote science, one needs to be very careful that he or she sticks to the science as per the recommendation. And those recommendations are very, very important because they're based on certain evidences and the grade of recommendations are very important. What is the recommendation of 2019? In polyarticular form of psoriatic arthritis, the conventional synthetic DMARD should be initiated rapidly with methotrexate as the preferred drug, especially when you have skin and joint involvement. In patient with monoarticular or oligoarticular, particularly with poor prognostic factors, such as damage, joint getting eroded, high ESR or CRP, or dactylitis or nail involvement, a conventional synthetic DMARD should be considered. Very important, should be considered. That's very important work. What more? In patient with peripheral arthritis, an inadequate response to at least one, not two or three combination, even at least one conventional synthetic DMARD in optimum dose if you have given therapy with biological DMARD should be commenced when there is a relevant skin involvement, an IL-17 inhibitor or IL-12/23 inhibitors may be preferred. So they are trying to give that if you have a joint involvement, you have used a conventional synthetic DMARD and you have used in a correct dose, and you're unable to get a control of the disease, and the patient is quite, feeling uncomfortable with the skin involvement as a predominant component, the drug of choice is IL-17 inhibitor or IL-12/23 inhibitor was taken. And this is very, very important to understand that skin predominant disease with arthritis is treated differently. Now, there's another subset of patient. In a patient with peripheral arthritis, inadequate response to at least one conventional synthetic DMARD, no, and that is not the skin involvement, peripheral arthritis, at least one biological DMARD, or when biological DMARD is not appropriate, a JAK inhibitor may be considered. So if you have a methotrexate, you have given to the patient 25 milligram or 30 milligram, and the patient has tolerated well, but the disease is quite devastating. You have a peripheral joint which are just not getting controlled, and the patient requires something which will be definitely going to add to the quality of life. Consider biological DMARDs, and if you can't use a biological DMARD, use a JAK inhibitor. So straight away JAK inhibitors comes in a poorly controlled peripheral predominant psoriatic arthritis. But if a patient has a mild disease and inadequate response to at least conventional synthetic DMARD, and in whom neither biological DMARD nor JAK inhibitor is appropriate, you can use a PDE4 inhibitor. So PDE4 inhibitor, despite it being a small molecule, is considered clearly by the recommendation for the milder diseases where conventional synthetic DMARD has not worked. Now, if you have controlled the disease well in patient with sustained remissions, cautious tapering of DMARD may be considered. Don't be in hurry. Go low and slow. Don't be in hurry of changing the drugs too frequent. So the EULAR 2019 updates for biological DMARDs for psoriatic arthritis, they say TNF inhibitors, IL-17 pathway, IL-12/23 pathways. EULAR says all the biologicals are actually same, and they do not want to differentiate. I will use TNF, IL-17 or 12/23 inhibitor on a hierarchy basis. It is up to the need of the treating physician or rheumatologist what he wants to use. So it also gives an individualization characteristic. So if I see a skin predominant disease, I may go for IL-17 or I may use IL-12/23 inhibitors. But if I see joint very badly damaged, I tend to use a TNF. So this is very, very important that when you use, we change. Now, the EULAR recommendation and the GRAPPA recommendation. So the GRAPPA is another group which does a lot of work in psoriatic arthritis, and this group principally has researchers from Canada and the America, etc. So you can have Indian members on the GRAPPA, but then predominantly comes from the Canadian and the American. So there was the last update was in 2015, and they are trying to update with newer recommendations. And the ACR, GRAPPA, EULAR, everyone, they have been incorporated into the GRAPPA. And they say again the same language: peripheral arthritis, axial disease, enthesial disease, dactylitis, skin and nails. And every patient is different and has a different combination of domains. So this is very, very important. Different combination of domains. You need to understand your patient before you start treating. And stronger recommendation on medication choices based on RCTs is what the American College of Rheumatologists they speak about. The National Psoriatic Foundation has the similar voice echoed. So cost effectiveness was not included. So they were very clear. This is the best drug. They do not take in account cost. So GRAPPA recommendation, what is the important thing? Useful for guiding the management of patients who have multiple manifestation and not only arthritis. Very good recommendation. ACR recommendation, more difficult to apply in Europe because they just say, you use this drug. They don't take in consideration of money and everything that is involved. They say, we go by science. We are logical only to the science. And it is not the real world patients in clinic. We are very, very cautious about how much money is involved, how to treat our patients. Because in India, you have to be very, very cautious. Step-up approach is a EULAR recommendation, and they take into severity into account. So milder disease you treat in a different way than a severe disease. Isolated enthesitis, because enthesitis is a very important domain. Not all the drugs works in enthesitis. So isolated enthesitis is not common. Often patients present with additional aspect of disease such as arthritis or dactylitis. So isolated enthesitis is not treated by the group. But we can still treat enthesitis, which can be disabling. You can give a local steroid if it's possible. And patients referred to rheumatologists tend to have quite significant involvement. And the NICE guidelines start with conventional demands, so no biologics. There's an head-to-head studies in psoriatic arthritis. So this head-to-head studies in psoriatic arthritis is SPIRIT head-to-head, where IL-17 inhibitor ixekizumab versus adalimumab was compared, and they looked into the ACR 50 and PASI 100 scores at 6 months. And there was another trial of EXCEED where secukinumab and adalimumab were compared again. Here, the ACR 20 was a primary. So if you see the SPIRIT head-to-head, so when you speak about drugs, you try to compare. So you see adalimumab and ixekizumab, they're almost similar at the end of 24 weeks. Whether it's an ACR 20 or 50, they are similar. There's not statistical significance of a difference. And again, when you see EXCEED, again at week 52, that is almost a year, almost similar ACR 20 and ACR 50 response. The other thing that you need to understand is a PASI. So if you see PASI at scores, ACR 50 PASI scores 100, you will see that your IL-17 pathway is actually very, very good, and you will have a robust data where it says that this drug works quite well. It comes from the superiority over adalimumab. So when it comes to skin, this pathway of IL-17 is quite good. And when you compare the similar thing with secukinumab, you get a similar result. So IL-17 pathway on any given day is actually statistically important when it comes to skin important. So, but when it comes to musculoskeletal domain, it is same. You use TNF or IL-17. Musculoskeletal domains are similar. When it comes to cutaneous domain, IL-17 is better. So this is how you have to get the idea. How a doctor will write a prescription based upon what he has scored. And there's a maximized study where they have used secukinumab 300 milligram or 150 milligram. And then they compared psoriatic arthritis and axial disease. And they said that if you use optimum dose of secukinumab 300 milligram, it shows rapid and significant improvement of SR's 20 response at week 12 in psoriatic arthritis patient with axial manifestation and inadequate response to anesthetic. So this is how it is important. You will see secukinumab 300 milligram curve as well as 150 milligram. So at the end of 12 weeks, they are almost similar. Then you see the Berlin MRI score of entire spine. And then you will see that there is some change which is over and above in 300 milligram dose. So if you see axial disease, by MRI scores, you are actually doing much better when you take 300 milligram of secukinumab. And if you see the sacroiliac joint, again you will see the similar trend, compared to a placebo. So it's very, very significant. The Discover study, Discover 1 and 2, was using guselkumab, which is, again, IL-1223 pathway where you use block only the P90 domain, guselkumab. So again, you will see that there's a statistical significant improvement when you use guselkumab over a placebo. So guselkumab is quite better when compared to placebo. So we don't do in the real world placebo control. We want to use actually drugs. So this is the end point. So IL-23 inhibition and axial psoriatic arthritis. If you use for axial psoriatic arthritis, ustekinumab and risankizumab did not achieve key points. However, guselkumab has shown benefit in axial symptoms. And PsA is not specific for axial disease. It is impacted by peripheral arthritis. So this is where some changes needs to happen over a period of time. Now coming to today's domain. Now why I talked about this? Because these drugs are also there in the market, and that is where there will be a significant tussle between JAK inhibitors and the biological in a difficult to control psoriatic arthritis. For tofacitinib, we had OPAL Broaden, OPAL Beyond, which shows efficacy in terms of joint and psoriatic arthritis, and effect on skin is less versus other therapies when you compare with 17 and 1223. So when it comes to joint, yes, tofacitinib is quite good, but when it comes to skin, it will not be as good as compared to IL-17. So that one has to keep in mind, because patient preference may be skin over and above joint. Some patient may say joint problem over and above skin because they can cover this. So this is how you need to understand patients' requirement. And new JAK inhibitors in development, which is now approved, is upadacitinib, where you have a select psoriatic arthritis, where they compared with adalimumab. So there's a significant response on skin as well as significant improvement in musculoskeletal domain. So another JAK which we look forward is upadacitinib, which is not available in India. And filgotinib is a penguin study. Filgotinib has gone off the radar these days because of a specific toxicity. So when you use the targeted therapy, as a doctor, I also look into some things which are like infection rates. So when I take in consideration of patient, whether I have to use the JAK inhibitors, whether I have to use the biological, I also look into whether the patient has a higher risk of getting TB, sepsis, opportunistic infection, whether the person has a heart failure of the comorbid condition that they have. So this is very, very important. Then you have, if you are going to use IL-17 inhibitors, you are going to look about IBD. You don't want an inflammatory bowel disease patient given IL-17 inhibitors. You don't want the patient who is on IL-17 inhibitor has a candida infection. So you would like to see the skin, because many times patient may be just applying the steroid and allowing, and they are on methotrexate. They may get psoriasis, and then they may also have a tinea. So you don't want to use this drug when you have candida or a tinea, etc. And you always look into the mouth to see oral candidias. If you want to use ustekinumab, you just do not want inactive infections, including TB. When you want to see tofacitinib, no active TB, no serious infection like sepsis, opportunistic infections, hepatic impairment, pregnancy or lactation. And there can be higher risk of venous thromboembolism and herpes zoster. So get back into the history, get back into the vaccination history also, and look into all these. So vaccinate patients many a times. So if you have a lead period and you can vaccinate against herpes zoster, or if you can identify hepatitis B, C status, and want to vaccinate these patients, please vaccinate. And then look into infections like TB, whether it's a latent or active. So the personalization of treatment is important. We recognize the heterogeneous nature of the disease. We categorize different domains. We try to understand main issues before we prescribe a drug. We also check into the comorbidities like uveitis, IBD, diabetes, etc. We also look into pregnancy. You can't give a JAK inhibitor during pregnancy. The only safe drug would be using a TNF inhibitor, because we have the legacy of having information about what drug can be given in pregnancy. You also look into the cardiovascular side effect risk profile. You don't want to give a TNF inhibitor with a heart failure. This is a shared decision making. You just don't take decision based on what you understand. You need to explain to the patients, and when the patients agree, you actually offer the therapy. So decision domains, the biggest decision maker is disease domains. So if you have an axial disease, you can use either TNF or IL-17. You can even use JAK inhibitors. You can use you are not supposed to use apremilast, ustekinumab, or IL-23p19 inhibitors like guselkumab because they do not work on axial disease. If you have a skin disease, you use IL-17 or you use IL-23 inhibitors like ustekinumab or you use IL-23p19 inhibitor, which is now better, and these drugs are better than TNF. And if you have a comorbidities like IBD, you can use TNF inhibitors or JAK inhibitors. You know, JAK inhibitors are approved for ulcerative colitis also. So this is how you should know your disease, your drugs. So the concluding remark is, before I write a prescription of psoriatic arthritis, I try to understand the patient's requirement and their problems. And there are guidelines which are evidence-based. They help to give me an insight what is the drug appropriate. And what we require is head-to-head trials, which are not available, but whatever we have as an information, we extrapolate all these information and then we share the decision with the patient to give a reasonable outcome in psoriatic arthritis. With this, I end my talk. So I would request IDOC, to pass on the baton to Dr. Nikhil.
Yeah. So, hi, good evening, everyone. So, mainly I will be discussing JAK inhibitors, its role in rheumatoid arthritis, and mainly I will be discussing about how it works, what are the contraindications, how we need to use JAK inhibitors, and we need to be cautious in its use. So, tofacitinib was basically approved as a therapy for rheumatoid arthritis by FDA in 2012, and a lot many drugs have recently come up, as Dr. Bimlesh sir has already described. There is this decade has actually been a game changer for rheumatology patient. They have lot many options. So, first of all, let us understand the JAK STAT pathway, how the JAK inhibitors are different from biological DMARDs. The biological DMARDs, they mostly work in the extracellular space. They inhibit, like TNF blockers, they inhibit extracellular TNF. Tocilizumab, it inhibits extracellular IL-6, but this JAK inhibitors, they inhibit basically is the intracellular molecules. The cytokines, what happens, they bind to receptors, transmit inflammatory signal inside the cells by JAK-STAT signaling. And here is these JAK inhibitors, they hit the molecule. The inflammation is hit where ideally it almost originates. So this JAK-STAT signaling, you can see the cytokines, they activate JAK and they get phosphorylated, and then the JAKs, the STAT then bind at the receptors and are phosphorylated by the JAKs, and then the STATs, they translocate to the nucleus and alter the gene transcription. So a lot of cytokines are produced by this. So tofacitinib or JAK kinase inhibitor, they prevent the STAT activation and blocking the signaling pathway, and then inflammatory cytokines production is further that is inhibited. So these molecules, you can see the mechanism as I explained, and JAK, you can see so many molecules are part of JAK activation. All you can see, almost all the interleukin cytokines, they are regulated. They are basically produced by JAK STAT activation, and it is at this site these molecules they hit You can see IL-6 will be, the tocilizumab will inhibit only one cytokine, one interleukin, but JAK stat will inhibit all of the interleukin and cytokines. Being agents that produce so much reduction in the inflammation, they are also have higher side effects, I would say, as compared if we hit one molecule. So we have to be careful and judicious in its use. So tofacitinib, it binds to JAK1, JAK2, JAK3 family of tyrosine kinase. It was the first approved JAK inhibitor. FDA approved it in 2012, and India also it is being approved by DCGI, and globally approved in rheumatoid arthritis, psoriatic arthritis, ulcerative colitis, even ankylosing spondylitis, and the juvenile idiopathic arthritis. So the indication would be intolerance or inadequate response to methotrexate. In most of the cases where you have used either methotrexate at full dose, 25 to 30 milligram, or triple DMARD therapy has failed, then you can either use JAK inhibitor or other biologicals, depending on the patient choice. As Dr. Bimlesh sir said, you have to be choosy about the patients in whom you need to use which biological, because they have certain contraindications, they work better in certain conditions, they would cause side effects in certain type of individuals. So it has to be a individualized approach. All is your patient that you need to see whether rituximab would work better, whether ILD is there, interstitial lung disease is there, then you need rituximab, or whether other comorbidities are there. The patient is already a case of cardiovascular disease, diabetes, where the JAK inhibitors will probably increase their risk further, having thrombosis. So you have to be very choosy about your patient in whom JAK kinase or other biologicals where TNF blockers, like they are TNF blockers, can be used quite safely in pregnant female or lactating female, where these molecules are contraindicated because we don't have any data. Even methotrexate, you need to be cautious in lactating female. It is ideally not to be used in pregnant, and whether patient is planning pregnancy, again, you need to stop it 3 months prior the patient is planning pregnancy. So screening before starting tofacitinib, you need to look for active TB or latent TB. If either of these things are present, you can't start these molecules right away. Viral markers, you need to see. Lymphopenia, if absolute lymphocyte count is less than 500, they are contraindicated. If hemoglobin is less than 8, they should not be started. If neutropenia is there, absolute neutrophil count of less than 1,000, they are again contraindicated. And also a lot of alteration should be there if patient is using antifungal agents, then the drugs which increases their toxicity. You have to be careful when you are using, and definitely in CKD patients, you need to be careful, and also in CLD patients, in transaminitis patients, they may increase the risk of transaminitis. So again, as I said, it has to be an individualized decision, because lot of rheumatoid arthritis is again a disease with lot of heterogeneity, and it is a patient may have a monoarthritis, may have polyarthritis, may have interstitial lung disease, may have amyloidosis along, so may have episcleritis, and may have a cardiovascular disease, which increases to as high as risk in diabetes. So you have to be cautious in every molecule which you use. So there are a lot of studies in rheumatoid arthritis, and it has found to be efficacious in even methotrexate naive, methotrexate inadequate, DMARD inadequate response. Then even in TNF inadequate response, it has worked well. Psoriatic arthritis, sir has already discussed, and sir has also discussed the newer molecules. Unfortunately, the new selective this JAK inhibitors, upadacitinib and filgotinib, is not yet available in India, but surely they would be coming soon. So we have to look at the toxicity. The risk of infection is a major concern, and it is almost equivalent to biologicals, but in some infections it is high, especially herpes zoster. The risk of infection is quite high as compared to biologicals. Other infections also, the risk is almost equivalent. Tuberculosis, non-tubercular mycobacterium, Cryptococcus, toxoplasmosis, the nasopharyngitis, UTIs, upper respiratory tract infection, the risk increases, their frequency increases. Herpes zoster is more common, as I already told. CMV infections may occur. Other viral infection like JC virus may occur. Cytopenias have been reported with tofacitinib, and they are not that uncommon. So you need to keep an eye on these. The reports, the blood tests have to be done regularly. Anemia, leukopenia, neutropenia. Once they occur, you need to stop these agents because they can lead to, again, further bone marrow suppression, and patient may be in a soup. DB, there's definitely increased risk, and these drugs carries a black box warning for that. Dyslipidemias are quite common, which we see in our practice, and definitely they may increase the risk of cardiovascular disease due to dyslipidemia. The GI perforations have been seen. The GERD symptoms are increased. Transaminitis, it can be seen in patients, and increased CPK levels and muscle weakness may again be a complication, and they may increase creatinine by decreasing its creatinine clearance. Malignancy risk is also shown to be a bit higher in patients on tofacitinib. So the key features of this tofacitinib are they are the first oral approved JAK inhibitors for rheumatoid arthritis treatment, and unique mechanism of action is there. They hit where the cytokines, the JAK-SNAT pathway, where there are a lot of cytokines they are produced. So it hit as that pathway. It has a rapid onset of action, and it has proven efficacy and safety. Sustained efficacy is there for 8 years, and long-term safety profile has been seen in patients, and there are studies for even up to almost 10 years. So where is its place in therapy? So as a agent when DMARDs have failed, so the EULAR, the ACR guidelines, mostly they put these molecules when the methotrexate or a combination of DMARD, sulfasalazine, leflunomide, hydroxychloroquine, they have failed to produce the patient in remission. Then these agents may be used. So, or then depending on the patient profile, as I told, which the patients, those who are at risk, the contraindications are there. If latent tuberculosis is there, then again you need to be you can't use these agents directly. So you have to have a proper patient selection so that these patients may not get side effects, or these agents do maximum benefit to your patient. Psoriatic arthritis, sir has already discussed. So, to summarize, the patients of rheumatoid arthritis who have inadequate response to DMARDs, or who are not tolerating DMARDs, and you are selecting a proper patient for your tofacitinib use, you can use these agents in a 5 milligram twice a day dosage. They can be used as monotherapy or in combination therapy with methotrexate or other DMARDs, and they have generally shown good results to the patients. For maximizing your patients with sustained remission, you need to be cautious. You need to do some tests regularly in their monitoring, and again, choose your patient wisely. Thank you. I think we have some questions, sir.
Yeah, we have a lot of questions, Nikhil, and they're very, very interesting, and we can take so let me start with the question, and you have just addressed, and so it would be very nice, Nikhil, if you can answer this question. What are the
Yeah.
safety concerns with the use of JAK inhibitors? So, what you think which is available in our day-to-day practice, which is a very important aspect also, and what is available in the literature? Can you just put in few
Yeah.
words for the safety concerns?
Yeah, safety concern, as I told, if you select your patient wisely, you will be getting almost nil side effect or less side effect. But if you are selecting a patient who is already prone to the side effects of that molecule, you will definitely land up in trouble. The patient will land up in trouble. There are a lot of there's high risk of infections, as is with the other biologicals. Herpes zoster is quite common in these patients on JAK kinase inhibitor, and also they are being used in combination with methotrexate, which also increases the risk of herpes. Then DVT is the risk is increased. The dyslipidemias, transaminitis may cause muscle weakness. The patient generally comes up with complaints of lot of upper respiratory tract infection, UTIs, which we see in our practice, dyslipidemias, and many times we are seeing severe infections of pneumonia, sepsis. They are again common in these patients, which we see quite a lot because its use has been they are rampantly being used or maybe misused also, and we are not using proper vaccination to our patient before starting these.
Okay. So, to add to what Dr. Nikhil said, so there were certain learning objectives. And I clearly remember the first patient I used was way back in 2014-15 when the original Gelzans was not even available in India. So that was the amount of information and euphoria about the drug. I also learned and burned my finger in treating. So can we just put up in few words? Commonly, if I see an elderly person who has too many comorbid conditions, who has been on steroids for a long period of time, who has an uncontrolled diabetes, these are the people where you get a highest risk of herpes zoster. So one of the drug which I would never like to give if a person is on steroid is JAK inhibitors. You are actually adding fuel to a fire where your herpes zoster incidence just goes up. Selecting older patients, again, you have a higher risk of herpes zoster. And this is what is proven in the science. So if I go by single one complication which is so rampant is herpes zoster, I would try to use least number of other drugs. For example, I use tofacitinib and methotrexate, but not too many drugs because again you increase the risk, higher age, and uncontrolled diabetes. But it is just not herpes. The incidence of UTIs are also very high when you are treating these patients. You get every time you treat UTI, you stop the JAK inhibitors, you restart, you get a UTI again. So there are certain specific population where you can't just go on using this drug because of recurrent UTI. The other thing which I've learned is GI issues, like some patients just can't tolerate this drug. And I will tell you the reason. Since JAK inhibitors principally act on the IL-6 pathway, and we now know that IL-6 pathway, when you use this drug, say Actimera, you have a higher chances of GI perforation because of diverticulitis or diverticulosis. And we can't screen this diverticulitis or diverticulosis. A good number of elderly patients had the very bad pain abdomen when they were started on JAK inhibitors. You stop the drug, they have. So these are something. But then, what Dr. Nikhil said, combination of few drugs with tofascitinib. So you have a hepatotoxic drug like methotrexate. You have also another hepatotoxic drug which is tofascitinib. So you need to monitor them very close, very, very closely. Your lipids can go abnormal. Your counts can fall suddenly. You can get higher risk of infections. Your DVT risk is higher. You also have certain warnings that may come up over time, like cancers and others, because we have not used for years altogether. For methotrexate, we can say we have used for 40, 50 years, but not for JAK inhibitors. So it's the early days of JAK inhibitors, and pan-JAK inhibitors are very, very dicey. So now we are going to selective JAK inhibitors. We don't want to block all these uh, cytokines because they are part of our homeostasis. And the more you have selectivity, you will have then lesser side effects, and you have a selective side effects also. So this is an add-on to what Dr. Nikhil said. Dr. Nikhil, another question is, please elaborate the safety and efficacy of tofascitinib when you want to compare it with TNF inhibitors. What is your take home?
Yeah, if you see the practical aspect, maybe we are using more tofascitinib as compared to TNF inhibitors in patients of rheumatoid arthritis at present. But if we see ankylosing spondylitis, the TNF usage, I would still say tofascitinib has higher side effect profile as compared to other biologicals, just for one reason, as sir already told. It is a non-selective JAK inhibitor, and the homeostasis is disturbed, and definitely when pan cytokines will be inhibited, obviously the impact would be more, and the side effect would also be more. So that is my take, that yes, I am seeing more side effects in its usage as compared to TNF blockers. Then now comparing the efficacy. If you see, if efficacy is almost at par with TNF inhibitors, and what we see is the long-term sustainability. The long-term sustainability is still, because early days are there, so it will take time for us also to see how long they are sustaining the disease in remission.
The good part about tofascitinib is it's a small molecule. So when you stop this drug, you probably, give a chance for the body to recover faster compared to TNF. So this safety aspect is very important. That you stop the drug, and within few days, the effect of the drug goes off. So you can start and stop if there's an infection. So that's big. Second thing is that when Dr. Nikhil said sustainability. So now we have sufficient data with certain drugs, say TNF inhibitors especially, that they can be used for a prolonged period of time. Say whether it's an etanercept in rheumatoid, etanercept in psoriatic arthritis, etanercept in ankylosing. These drugs do not have loss of efficacy. So around 60-65% of the patients are doing reasonably well over years. The secondary, failures are quite seen over a period of year. When it is said about tofascitinib, it is also believed that the secondary failures would be less, but it is not the truth. The redundant pathways in rheumatoid especially can become active. Tofascitinib in efficacy in certain diseases is quite less compared to TNF. Say, for example, ankylosing spondylitis. For me, tofascitinib is a poor man's choice. The TNF inhibitor supersedes in its action, efficacy, in certain domains, the axial disease domain. It is quite superior. And that's how it is. So the third question, Dr. Nikhil, is can JAK inhibitors be used as monotherapy in psoriatic arthritis with acceptable efficacy? If not, which agents should be combined with them? I will take this question because I spoke on psoriatic arthritis. There is nothing which says that you can't use a monotherapy in psoriatic arthritis. You can use a JAK inhibitor as a monotherapy. The individualization allows you to look into a lot more aspects. What we know is that if you have a joint disease, JAK will work, TNF will work. If you have more skin disease, IL-17 will work. But there are some certain subsets of patients who may not be tolerant or who may not be or may be averse to use a biological agent. So just take out the biological agent from the equation and just say methotrexate versus JAK inhibitors in psoriatic arthritis as a monotherapy. Then you will see JAK inhibitors supersedes methotrexate in psoriatic arthritis by leaps and bounds. No doubt about that. With acceptable efficacy. Now, if you want JAK inhibitors and methotrexate combined, definitely is as good as any of the TNF inhibitors. So why not a monotherapy? So that's one of the advantage about these drugs, JAK inhibitors. It can be used as a monotherapy, whether it's RA, ankylosing, or even psoriatic arthritis. But it will be some subset, a quite small subset of patients, not all. A good number of patients who are refractory or having difficult to disease, control disease, you may require different domains to be blocked so that you can get over. So what drugs can you combine? You can combine leflunomide with and methotrexate with JAK inhibitors in psoriatic arthritis. But you do not combine JAK inhibitors with a biological agent. That's more important. So that would be horrendous. But there is you can use any of the conventional synthetic DMARDs along with the JAK inhibitors, but not biologicals with JAK inhibitors. Which non-tofacitinib JAK inhibitors are effective in psoriatic arthritis cases? Definitely upadacitinib. Non-tofacitinib JAK inhibitors, that is basically a selective JAK inhibitor like upadacitinib is effective in psoriatic arthritis, and so is the other drug, which I was any drug which works basically on filgotinib, on on JAK inhibition of JAK1 basically. What is your take on higher prevalence of herpes zoster virus infection and need of prophylactic vaccination and clinical monitoring in patients? Dr. Nikhil, your question.
Yeah. Basically, vaccination is indicated. The herpes zoster now, the vaccine is available in India, and it is indicated in patients who are on immunosuppression and who are more than 50 years of age. So methotrexate patients who are taking methotrexate, tofacitinib, biologicals, they all require this vaccination to prevent herpes zoster.
So, quite surprising is observation, a 38-year-old individual getting herpes zoster. So this 50-year issue is quite good for Western world. In India, you have a higher chances of infections. So for Indian data, we have to have our Indian standards of information, which is lacking here. So the manufacturer or maybe the science available from the Western world says 50 years. After seeing younger patients getting herpes zoster with JAK inhibitors, especially tofacitinib, I have a reason to ask myself, why not even younger patients who can afford this vaccine? But the problem is the vaccine is quite a subcomponent vaccine. Shingrix is now available, but not available in the market, but available in India. It will be available by 3rd week of April. But that is so costly. That's the question number one. So the patient has to pay, a price of around 20,000 to be completely vaccinated with an effectiveness of 90% and or more for prevention of herpes zoster. So that's good or bad in one way. You can prevent it, but at a very high cost for a drug which is so reasonably priced in India. Question: this is one part of the thing. The thing is that if you do a vaccination, at least you will mitigate the complicated type of herpes zoster. You do get complications in herpes zoster. Sometimes you get a multidermatoma, and sometimes you get, it is said that if you get herpes zoster, you don't get herpes zoster again. That's not correct. You can have a herpes zoster coming up again and again in some patients who are taking tofacitinib. So don't think if you have had a herpes zoster, You don't require a vaccine. You do still require a vaccine. And there's one misnomer that all the herpes is on the skin. You can have a visceral herpes also. So that you can have just pain in your chest, and it's just not dermatoma. So you need to understand there is another variant which is not seen by our eyes because it's not coming on the skin. So this is another problem. So what are the indications of to begin with JAK inhibitors in RA patients? Dr. Nikhil, how do
Yeah.
you start your JAK inhibitors in RA? When do you give JAK
Yeah,
inhibitors?
I give JAK inhibitors who have failed DMARD therapy, who have failed adequate dose of methotrexate, probably at least 25 milligram with combination, maybe triple therapy, hydroxychloroquine, sulfasalazine, or a combination with leflunomide, who have not worked well for at least given these molecules for 6 months, and patient has not responded. And it's that patient in whom I find that this patient would do well and also would be less susceptible to side effects. So as you already told that the old patient, the patient who has diabetes, cardiovascular risk is high. So I generally avoid giving those patients or these JAK inhibitors. So already those patients who have failed DMARD and those who are the right candidate for JAK inhibitors, I start using them in those patients in rheumatoid arthritis.
Fantastic answer. How early is reduction in radiographic progression observed in RA patients taking JAK inhibitors? I think you are going through those trials with RA beam, begin, etc. So can you go back to one of those slides, Nikhil, if you can share that slide,
Yeah.
because that is a very interesting slide to understand. Because that was also one of the search domain areas where they were looking into whether they can see radiographic retardation.
Yeah, yeah,
Yeah, go back.
yeah. This is
Yeah. Here comes. So if you see among this study, so tofacitinib, first they identified whether the tofacitinib will work in patients or not. Then they identified what dosage it is good, whether you can use in methotrexate naive or DMARD inadequate responders or DMARD, failures compared to non-biological DMARD. So they went on. So in one of them, the study, what was it? This
this
is
was this was in this trial, sir.
oral scan.
Yeah, oral scan, and it was seen that at 18 months, they could actually it was checked only at 18 months, not before. So they checked that at 18 months they definitely prevent radiographic progression in rheumatoid arthritis and prevent erosions and deformities.
So I just confused with RA beam because that was for the other drug, uh, baricitinib. So it's the oral studies. So they have already looked. So it does prevent the radiographic retardation. There's no doubt about that. So we go back to the question, but when, because see all these retardation, the studies cannot be done, cannot be concluded in say 6 months. You need to do a longer, interval to actually see that change. So if I use an MRI to see what is the bone marrow edema coming down with different agents, then it would be a different ball game. But in practical world, when you do the studies, you look into the modified sharp scores. So almost 18 months to 2 years to demonstrate the change. Now comes the question, which is so interesting, is the ninth question. I think, how would you how would you rate the safety of profile of various JAK inhibitors? So I will take this question. The broader is the JAK inhibition. So pan-JAK is bad. Selective JAK inhibitors are good. So you go for JAK1 blockers, predominantly. That is good for rheumatoid to begin with. But if you have a different profile of a patient, so we are just not speaking of RA or psoriatic arthritis of AS. So let's see what the patient has. So depending upon what the patient has, if someone has an atopic diathesis, the type of JAK inhibitors that you want to block is different. When you have a rheumatoid arthritis, you have a different. When you have a skin involvement, it is different. So, say for example, Tofacitinib works so well in psoriatic arthritis and psoriasis, but baricitinib not that effective. So you have to take in consideration that all JAKs are different, and they have a different subsets of patients where you use it. Baricitinib can be used, for example, in connective tissue diseases, while tofacitinib has not been well studied in connective tissue disease or has not been found to be much effective. So the rules of the game is very difficult to be predicted. It is an early days. So depending upon what you manifest, you may get it. If a patient has alopecia and has a rheumatoid, for me, I will jump for a JAK inhibitors on the day one along with methotrexate, because these two agents are the best known agents which can reverse alopecia in a patient who has a rheumatoid arthritis. So that's very, very important. Then you have, for example, we are talking of a JAK, but if a patient has a rheumatoid arthritis who is seropositive, strongly positive anti-CCP rheumatoid factor, difficult to treat condition, you will not think of a JAK inhibitors. Probably in India, you will think of rituximab. So it all depends upon what the patient has. So this is a difficult to answer the question, but fantastic question. Which JAK inhibitor is the most effective in cases of refractory RA? I will take up this question because this comes from the scientific analysis that baricitinib along with methotrexate is the most effective combination for RA. This is followed by methotrexate and rituximab in seropositive RA, while it will be lesser for adalimumab and methotrexate, and even lesser and almost similar for methotrexate and tofacitinib. So if you want to say that which is the best drug for badly controlled rheumatoid arthritis, baricitinib. So the ACR 70 is as high as 47% with this combination. Do JAK inhibitors work well in patients who haven't responded to DMARDs? Dr. Nikhil, your call.
Yeah, definitely. They are indicated at that point only. So those who don't respond to DMARD, they many of those patients, they do well with JAK inhibitors, and that is again a pure indication of its use.
Okay, fantastic. So Nikhil, you need to stop your share screen so we can get back to, thank you. So with this, I think we covered almost 10 chats.
Yeah.
So would like to just ask the host if there are any more questions. Vivek, any questions that you can see or you have with?
I think, sir, each and everything is clear, complete.
Any questions that you feel that should be addressed? So the take-home message is very, very simple. Whether it's a rheumatoid, ankylosing, or psoriatic arthritis where you want to use tofacitinib, we need to first understand the patient. After understanding the patient, we have to understand the risk profile of the patient. Once you see the risk profile and the type of disease domain, you would like to see whether the first line agents have been exhausted before you use the second line or the third line agent. As on today, we can use JAK inhibitors even before biological DMARDs, at least because of the cost consideration in India. We all do it. Nevertheless, the safety aspect is missing in India because of the rampant misuse of JAK inhibitors. And we know the reason. The screening tools are costly. The agents to vaccinate are even worse. They are even more costlier. And we see more and more side effects than we have seen in the data. But our data is a real world data. Every center who has, whichever may be A, B, C, D, E, F, you take on the data of herpes zoster, the amount of herpes zoster that we have seen in last 2.5 years. It is enormous. And we have seen even tuberculosis with this drug. We have seen DBTs with their drug. We have seen funny types of infections, UTIs, GI issues with this drug. So nothing to hold back that these drugs are very important. We need to be very rational in using these drugs. This drug requires a lot of expertise, know-how, the science behind and the logic behind using these scientific molecules. So our responsibility is just not prescribing, but prescribing in a social circumstances for a person or a family and society at large. So it is our responsibility, along with our partners here today, CIPLA, to understand indiscriminate use of JAK would bring a bad name to the drug and the medical fraternity. It is very important that we reach with this molecule to the people who understand these drugs, the implication of the drugs, so that our patients are safe and the science is utilized in the positive direction and never misutilized. So with this, I would thank my dear friend, Dr. Nikhil and Sipla for the wonderful time of sharing knowledge and information. And thank you again, Vivek and Saurav, if anything from your side.
Thank you, sir, for your time. And what I learned from this screening is very important before using any tofacitinib. And instead of using left and right, drug must be used under the guidance of consultant, sir. I think most of the questions are covered, and almost all doubts are clear. Thank you, sir. Thank you for your time. Thank you, Dr. Nikhil.
Thank you.
Thank you, all the people who have participated and have spent their time and have come with the beautiful questions. I never expected this good standard questions coming up. If they just come from your team, it's exciting standard questions. Thank you again, everyone who has spent their time. Thank you, Dr. Nikhil. Thank you,
Thank you, sir.
Sipra, and your
Thank
team.
you, Sipra.
Thank you, sir.
Okay.